So the question is, how severe can thrombosis get and how does it lead to death?
Thrombosis, how severe is the thrombosis can occur? Huh? Is that the question?
Right.
Yep. See, yes, it is particularly in this COVID scenario, we have seen, very good number of cases where despite this as delivered in the talk, despite on anticoagulation, few patients developed, thrombosis. Particularly in those patients who are critically ill, okay, like who are on ventilation, who are on non-invasive ventilation, who are, morbid obese, who cannot move their, limbs, okay, actively. These are the patients where there's always a chance of development of thrombosis in these patients. We should closely monitor the inflammatory markers, what we call main inflammatory markers. What we monitor here in India is CRP and D-dimer. They're very important in, if any rising trend of D-dimer predicts that, there is a thrombus sitting somewhere else or, beginning to form, and then we have to change the medication or, upgrade the doses of anticoagulation. And we have witnessed sudden deaths, okay, sudden cardiac events, sudden pulmonary embolism leading to, okay, high mortality we have witnessed. And on the other hand, there are a few patients where they are very sensitive to higher dose of anticoagulants. We have seen massive intracranial hemorrhage with intraventricular extension as a side effect of anticoagulation. So in a nutshell, it is a very delicate balance. It's an art of to manage these COVID patients to prevent from thrombosis. On the other hand, they may end up in,
All right, thank you so much for that answer, and I will pass
it on. Neha, one more, Rama. Just a question for Dr. Kiran Kumar Makineni. What is the most common or rare cause of thrombosis have you seen in your clinic? You are on mute, Andy. You are on mute, Andy. Kiran Garu.
Yeah, sorry. Yeah, hyperhomocysteemia is the most common one we see, we evaluate. And most common cause is patients, orthopedic patients or patients on prolonged bed rest. These two are the most common ones. And factor V laden you are talking about, that rarely comes positive in Indian scenario. We get in young patients, one of the most rare thing we see is factor V laden, because all reports in the Western literature, they tell it's quite frequent, but very rarely we see patient having factor V laden positive. We see a lot of cases on bed rest or post-operative DVT or patients on hormone replacement getting deep vein thrombosis, because in India, anytime someone wants to go to a temple, attend a marriage, attend a function, they take hormone replacement. So it's not just contraceptive. So you see good number of patients, young patients seeing on this thing. Thank you.
Thank you. Vijay and Neha, please.
Yeah.
Uncle, is it okay if I ask a question?
Yes, please go ahead.
Yeah, before I have my question, I just want to say it's an absolute privilege to be here among so much distinguished individuals. It was a massive educational experience for me, and I want to thank everyone for taking the time to spread this invaluable knowledge. My question is for Dr. Yogendra Akula. Doctor, is there a level, I mean, assuming such assay is available for us, of which, like, is there a level beyond which antithrombin 3 we need to be hypervigilant for renal vein thrombosis, like a certain level?
It's a good question. what happens usually, as I'm sure when you join in residency, this is what you're going to see is the way it works out is you suspect somebody is having renal vein thrombosis. You say renal failure patient, and you suspect a renal thrombosis, and then that's when you actually check antithrombin 3 deficiency. Now, it doesn't work the other way. So it's not like you check antithrombin 3 when you do hypercoagulable work for PE, and you see that antithrombin levels are high. There is no proven benefit to look for renal vein thrombosis at that point. Okay, so I'm hoping you'll get into residency, and all the young students here. The take home message from here is usually the way it works. The most common presentation that you're going to see on the floor is usually DVTs and PAs. You send them workup for hypercoagulable workup, including factor V levels, antithrombin levels, and other hypercoagulable workup, and you see antithrombin 3 levels. If they're elevated, that doesn't mean that you can go back and look. You have to go back and look for renal vein thrombosis. So the long and short answer for you is there is no clinical correlation between the level of antithrombin 3 and the risk of renal vein thrombosis. Okay. But the pathology, the underlying pathology is this: the antithrombin 3 levels, the decrease, and they're secreted in the urine. So you don't have to start looking for how low the antithrombin levels are to kind of diagnose renal vein thrombosis. So I'm sure as once you get into residency, you'll have much more experience, and you'll know what I'm talking about, right?
No, thank you, doctor.
Hopefully, it's not a roundabout answer. If you didn't understand, I can cut it down and
no, I understood.
One important question for Dr. Nagireddy Garandi. A lot of mothers are asking, have you seen Kawasaki disease in what's motively presented in US or any other places? And when we should be concerned, at what time we need to be concerned for infants and the people who are in young age? That was the question. Nagireddy Garandi. I think Nagireddy Garu left. We will pass on that question because I got it on my text. So I will ask Nagireddy Garu and I will pass on. So Neha and Vijay, can you please go ahead?
Kumar, I have a question to our pulmonologist, critical care experts in India. The question is regarding anticoagulation. What is the recommendation for patients who are being discharged? For example, if they see the patients have higher D dimer, both Dr. Vijay Kumar and Dr. Adusmilli, how long are you going to discharge them on anticoagulation? First question. Second question, what is the duration of anticoagulation? The reason I'm asking this question is some of our close friends and here they go home and some of them are dying.
We can't hear, and Yogendra Garu, you are.
My thought is probably is okay. So can you hear me now, Kumar?
Your connectivity is we can't hear you, Andy, probably.
Can you hear me
So
now?
if I'm correct, Kumar Garu, what I have understood the question from Dr. Yugandhar is.
What about now?
Yes, it's better.
Yeah, it's better now, Andy.
Right. Yeah. So sorry, Vijay Kumar, let me be brief. See, the most important thing is this post-discharge deaths that are happening in COVID patients. Okay.
Yep.
It looks like this could be related to thrombosis and hypercoagulable state. So my question to critical care, including Dr. Aduswani and you, is: are you discharging these patients on anticoagulation? First. Second, what is the duration that you recommend? And what is your experience regarding post-discharge sudden deaths that are happening in these COVID patients? Okay, are you able to hear or no?
Yes.
Yes,
We
sir.
can hear.
Do you want
please
me
go
to
ahead.
answer, or Kiran sir, do you want to go first? Right, I'm Dr. Mahati, sir. I'm sorry, that's my son's name. Sobhan Adsmuli is my son. He uses this computer for his online classes. So yeah, I'm Dr. Mahati. I'm the intensivist, sir. We are discharging patients with a prescription of 4 to 6 weeks of anticoagulants, sir. They are going on oral anticoagulants. We are putting them on Apixaban. If their D dimers are below 500 at the time of discharge, if they are anything above this, we are discharging them on Clexane, enoxaparin, so injectables. I personally have not seen cases coming back, but I have discussed with my pulmonologist. They had one case coming back with pulmonary thromboembolism, and that patient was not on follow-up anticoagulants because he was in the room for a week and he got discharged, and he came back in 4th week of illness, 4th week post being positive with a pulmonary thromboembolism. The second case was with the cardiologist. He was a young guy. He came with acute MI. Stenting was done, but there was a stent thrombosis and that guy died. He was a young guy. He was only 32 years old. Even this guy was a OP patient. He never got admitted in the hospital, so he was never on anticoagulants. But again, in the 3rd week of his post illness, he got an MI. So we as a protocol are definitely putting patients on anticoagulants 4 to 6 weeks, sir, based on the D dimer levels at their discharge plus the associated comorbidities. We are putting even young patients on anticoagulants because both the cases were young males. Yeah.
This is Dr. Kiran. We are seeing a lot of patients who are discharged coming back with arterial and venous thrombosis, but majority of them are patients either on antiplatelet medication or not on any thromboprophylaxis. I have only seen 2 patients in the last 2 months who are on low dose anticoagulation. Both were on dabigatran 75 mg dose. We have come back with venous thrombosis, but we are seeing significant number of patients with arterial and venous. We are seeing a lot of even arterial thrombosis patients, but most of these patients are either not on thromboprophylaxis or they are on ecosmo, which I think is not sufficient. Secondly, most of the patients who are admitted to ICUs are being advised thromboprophylaxis for, I think, 4 weeks. That's what it is happening in Vijayawada. I think Hyderabad, maybe they are giving for 6 weeks. I think 4 to 6 weeks for thromboprophylaxis is compulsory in most of the patients who are at high risk. But a portion of young patients who are risk is very low. They are coming with acute arterial events and venous.
So, Yugandhar garu, okay. So what in my experiences, yes, there were few cases which we have seen who have come with signs of pulmonary embolism and DVT as well. So for them, what we practice is somewhere between, it depends on how much risk factors this given patient is having, how much severity that patient was having. Sometimes, patient may be having a moderate disease, was in just a couple of liters of oxygen in the hospital. His inflammatory markers are not that elevated. Maybe 2 weeks is good enough. There is no enough gross data to prove or disprove this. but somewhere between 2 weeks to 6 weeks, depending on heartbeats and other. Key point is it's not the discharge time that what is important, but we have to monitor the inflammatory markers on a regular intervals. Maybe at least to beginning on the 5th day of discharge, and then followed by weekly ones till all the inflammatory markers are reasonably settled. And all these patients, when we look back in the data, two important markers that are very important. One is CRP, and second one is D-dimer. So when any of the these parameters started rising, that means that you have to increase the prophylactic dose to probably therapeutic dose 5 mg BD also we have given in a good number of cases. And when they are followed for 1 to 2 months, they're all reasonably good, sir.
Actually, I have seen few patients with raised D-dimer even after 3 months. Because what I am following is any of these patients with high D-dimer more than 3 to 4 times normal value, I am continuing thromboprophylaxis till it comes back to normal.
Absolutely agree with you, sir. This is completely new disease. How it is going to presenting in different individuals, we are not sure.
We are not.
Okay, we have to see the patients. Each patient, we have to see in a different manner.
As individual, yeah.
Very dynamic.
Yeah, only one thing that we are sure about is they definitely need anticoagulation, sir. Any hospital admitted cases, irrespective of being ICU, 100%. We have started prescribing anticoagulation to patients who have been treated in the room also. So yes, definitely prolonged anticoagulation use post-discharge is what we are following.
Yeah,
I think we can use something like Wells score or something routinely for all OPD patients also. If any of them is high risk, maybe we can prescribe them oral anticoagulants or low molecular weight heparin at home.
Just to give you how they are doing it in our North Houston area, the hospital system is surprisingly none of them are being discharged on any anticoagulation. Now, I'm not saying they're doing it right. We don't know how many of them are ending up in different hospitals, how much is the mortality. But the general practice here is they're not going on routinely on anticoagulation. And it'll be interesting to know if that has been a problem. And I don't know if President Trump is an anticoagulation. So he's. There's no correct information when it comes to Trump, but usually it leaks and it doesn't look like he is discharged on anticoagulation. So our practice here has been no anticoagulation unless they have some other proven DVT or P. So it's not being used as a prophylaxis on COVID patients when they're discharged. And I think only time will tell us if that has been a good practice or if Trump's otherwise. We'll see.
Actually, sir, the doses recommended in the US guidelines are also much lesser than what we are using. In ICU cases, we are not using prophylactic doses, sir. We are using therapeutic doses. So that's 1 to 1.5 mg per kg is what we have been using in the ICUs. And in the rooms also, they are at least on 1 mg per kg dosing. All admitted patients are on a little on the higher side. In US guidelines, they have proposed only 0.5 mg per kg of low molecular weight heparin, but yeah, we are on the higher side actually.
Yeah.
I think
Go ahead.
I think in US, I think they are waiting for proper guidelines because they have more legal issues than in India. So there is risk of bleeding. You prescribe something, they go home and bleed. You don't have guidelines, they may sue you. So I think they are waiting for proper guidelines.
Despite of using the higher doses, yes, there have been patients with some GI bleeds, but the incidence is very low. It is much lower than what we expected, despite of giving such higher dose of anticoagulants.
Thank you so much, Andy, for a wonderful conversation. Vidya, now we move on, and before vote of thanks, one more speaker is there. Roger mentioned.
All right, thank you, Dr. Pagliocco. So I would like to invite Ms. Usha Buddhaku, who has been active in helping us promote world thrombosis for the past 3 years, to give some closing remarks. She's a national